Good morning. My name is Asad Shah, and I'm a resident in general and cardiothoracic surgery at Duke University Medical Center. Today I will be speaking to you about pneumothorax and chest tubes. A pneumothorax is defined as the abnormal presence of air in the intrapleural space with secondary lung collapse. Here you see a picture of an anterior-posterior chest radiograph demonstrating a pneumothorax in the right chest. The arrow indicates air in the intrapleural space with adjacent right lung collapse. There are four main causes of pneumothoraces. The first is a primary spontaneous pneumothorax, which involves a pneumothorax caused by an unknown etiology in the setting of normal lung parenchyma. The next is a secondary spontaneous pneumothorax. This is a pneumothorax that occurs in the setting of known lung disease. Third is a traumatic pneumothorax caused by trauma to the chest. And lastly, there are iatrogenic pneumothoraces, which are caused often by healthcare providers performing procedures such as placement of central lines. Patients with pneumothoraces present in a variety of ways. They can be, in many cases, asymptomatic if the pneumothorax is small. If the pneumothorax is large, and particularly if it is a tension pneumothorax, it can result in circulatory collapse. Patients also present with acute chest pain that is often pleuritic in nature, as well as sudden dyspnea. Vital signs may indicate tachycardia. Tachypnea, diaphoresis, and decreased breath sounds on the side of the pneumothorax are also found. The diagnosis of pneumothorax is made both clinically and with imaging. Patients who are hemodynamically unstable or critically ill require a prompt clinical diagnosis in order to enact appropriate treatment. This typically involves listening for breath sounds on the side of the suspected pneumothorax. Additionally, diagnosis can be made and is more frequently made with a basic chest X-ray. This can demonstrate air in the intrapleural space and adjacent collapse of the lung, as is seen here on this chest radiograph, demonstrating a right-sided pneumothorax. The treatment of pneumothoraces varied depending on the clinical situation. A tension pneumothorax is a surgical emergency. A tension pneumothorax occurs when air fills the pleural space, collapsing the lung and causing associated mediastinal shift to the contralateral side. This results in hemodynamic instability. A tension pneumothorax is treated with immediate needle decompression upon diagnosis. A needle is placed in the second intercostal space in the midclavicular line. Typically, a 14 to 16 gauge needle is used. This will decompress the air in the pleural space and alleviate the mediastinal shift and remove some of the air on the side of the pneumothorax. This is, however, a temporizing measure, and then a standard chest tube must be placed after the needle decompression. The typical treatment for a pneumothorax is a placement of a chest tube, or what is also called tube thoracostomy. Before we get into the procedure of performing a tube thoracostomy, one must be aware that it can be a dangerous procedure associated with other complications. Associated complications occur in up to 21% of patients and include improper tube placement, pneumonia, empyema, and recurrent pneumothorax. On the bottom left-hand side, we see a picture of the distal portion of a chest tube, and on the right side, we see the pleurivac, which is the device that the chest tubes are connected to that collect air and can provide suction as well as an air-water barrier. The technique of performing tube thoracostomy begins with adequate pain control and sedation for the patient. These are very painful procedures and are in fact mini thoracotomies and are associated with a significant amount of pain. When possible, conscious sedation can alleviate the pain and anxiety associated with the procedure. Local anesthesia is always used with infiltration of the subcutaneous tissues above the periosteum and the pleura itself. In patients who may not fully cooperate or who are particularly anxious, gentle hand restraints may be useful to prevent inadvertent contamination of the sterile field. A sterile field is created typically in the mid or anterior axillary line in the fourth or fifth interspace. One dose of antibiotics, such as a first-generation cephalosporin, is given at the time of insertion. Tube selection varies based on the indication for the procedure. For pneumothorax, a smaller 20 to 24 French chest tube can be used, as only air has to be drained. For hemothoraces or larger fusions, larger tubes such as a 32 to 36 French chest tube should be used. The skin incision can be made at the nipple level in the anterior to mid-axillary line in the fifth intercostal space. Blunt dissection is then used to dissect through the subcutaneous tissues and muscle just over a rib using a Kelly clamp. The reason it is key to go above the rib is that the neurovascular bundle lies below each rib, and placing a tube in this area can lead to bleeding. The pleura is then punctured with the tip of the Kelly clamp, being careful not to injure any internal structures. After a hole is made, digital inspection is performed of the pleura to make sure there are no local adhesions and that the pleural cavity has been entered. Next, the tube is placed at the end of a curved clamp and inserted into the pleural cavity. Typically, the tube is inserted posteriorly and apically to drain any effusions. The chest tube is then closed to a closed suction drainage system, typically of Pleurovac canister, and placed at negative 20 mm mercury of suction. The tube is then secured in place with 1 or 2 sutures to prevent dislodgement. Lastly, a portable chest X-ray is obtained to determine and confirm accurate placement of the chest tube. Tube removal is variable and can occur within 1 day to many weeks after placement, depending on the indication and patient's clinical condition. Most providers keep the tube to suction for at least 24 hours to cause apposition of the pleura, and then take the tube off suction and place it to simple water seal. In summary, pneumothorax can have a wide range of presentations ranging from asymptomatic to life-threatening. In urgent situations, the diagnosis of pneumothorax should be done clinically, and this can be confirmed with a chest X-ray during elective settings. Tension pneumothorax requires immediate needle decompression and chest tube placement. And lastly, chest tube placement or tube thoracostomy is the mainstay of treatment for pneumothorax. Thank you.